So our next speaker is Dr. Jeannette Lin. Dr. Lin did an adult cardiology fellowship at UC Irvine, and then she spent a year with us at UCLA doing adult congenital heart disease. And since then, she has gone back to start an adult congenital clinic at UC Irvine, and she still joins us 1 week out of the month as an attending on our service. She specializes in adult congenital, but also in echocardiography and non-invasive imaging and stress testing. And she's going to talk to us today about functional testing in adults with congenital heart disease.
Thank you for that kind introduction, Jamil. I have a tough act to follow here, because if those of you who come from adult cardiology background, as I do, think of stress testing as a very, very dull, kind of necessary evil that is a part of our practice because we're always looking for ischemia. But actually, once you add in the cardiopulmonary component to it, the test actually becomes much more useful and provides a lot more useful information, and that's what we're going to talk about today. So we're going to cover three broad areas of functional testing today. We're going to talk first just about protocols. Briefly, we're just going to go over interpreting results, and if for those of you who would like more information about the physiology behind that, I would refer you to the 3-day cardiopulmonary exercise test symposium that is hosted by Harbor UCLA a couple times a year. And I think the third and most important thing are, what are the indications for functional testing? Why do we do it? Our patients almost universally hate cardiopulmonary exercise testing. They hate it. You put this clip on their nose, you strap this thing on their head. You know, they're very self-conscious in their 20s, and then you take pictures of them, and then you put them in presentations without their approval. This is actually one of my co-fellows from when I was a fellow. We volunteered him because he was the most fit person in the room, and then we took pictures on our cell phones to use in presentations. If you see Ahmanson Siddiqui in Texas, tell him I said hi. Most of us who do stress testing are very familiar with treadmill testing. And treadmill testings are used very widely in the US because we think, well, people here walk sometimes, and so they'll know how to walk on a treadmill, we hope. Whereas in Europe, the idea is because bicycle is used as a more common mode of transportation in Europe, that cycle ergometers are more well-suited for the European population. For the treadmill protocols, there are dozens and dozens upon dozens of different protocols, and each protocol varies in the duration of each stage, the grade of the treadmill, the speed of the belt at each stage. The most commonly used protocols would be the Bruce and the modified Bruce protocols, and that's what most of us are most familiar with. The workload when you're doing a treadmill exercise test is estimated based on the patient's body mass, the speed of the belt, and also the incline of the belt. For a cycle ergometer, the machine is actually able to increase the workload using an electronic braking system. That was a nice advance in functional testing. The main advantages of the treadmill are, number one, familiarity, especially for the American population. Even if they haven't ever used one, they've seen one and they kind of know how to walk on one. And also that it uses more muscle groups than cycle ergometry would. In cycle ergometry, you're using predominantly the lower half of your body, and as a result, you'll actually end up with a peak VO2 that's usually about 10 or 15% lower with cycle ergometry than a treadmill, because the treadmill is able to recruit more muscle groups. The disadvantages of the treadmill, as I mentioned, are that you're estimating workload, and anytime you estimate, you're going to introduce another source of error. And also because it's a stage test where every 3 minutes, for example, in the Bruce protocol, you're changing the speed, the incline, there's actually fairly large jumps in the workload with each stage. The cycle ergometer, the advantages are that the workload can be precisely determined in watts. There is a theoretical safety advantage too, because it's pretty hard to fall off a cycle ergometer. It's not rolling anywhere. It only has one wheel, so it can't go too far, and it's pretty much stationed for you. So especially for a younger population, the pediatric population, the cycle ergometers felt to be a little bit more safe. In the adult population, safety is probably not as big an issue. But the main disadvantage is muscle fatigue. For those of us who aren't accustomed to cycling, to fatigue, you may actually have muscle fatigue before you actually reach your maximal exercise capacity. And so for that reason, most labs, because they have the treadmill tests, usually for stress testing for ischemic purposes as well, can use the same equipment for the cardiopulmonary exercise testing as well. You order a cardiopulmonary exercise test, and the report gets sent back to you with lots of words and numbers that are hard to decipher. The one number that we glom onto the most for prognosis and for following the patients over a long-term period is going to be your maximal or peak oxygen uptake. Functional testing or cardiopulmonary exercise testing will give you all the same information that a normal plain stress test or stress echo would if you add that echo component in. It tells you about the patient's endurance, about how long they can exercise, about their blood pressure response to exercise, and especially in our patients who are mildly cyanotic or may have shunts, tells you about what their oxygen saturation does with exercise as well. And all of those things are very important, which as we'll talk about. The VO2 is the best single indicator of cardiopulmonary function that we have. It's a measurement of the highest possible oxygen consumption that a patient can attain for that particular type of exercise. It reflects, as you can see from this equation, basically the stroke volume times the heart rate, which is your cardiac output, multiplied by the cellular extraction of oxygen. You also get a few other numbers as well. Heart rate reserve is pretty self-explanatory. It's how much the heart rate increases during exercise. There's also oxygen pulse, which is basically the VO2 divided by the heartbeat. So it tells you basically the stroke volume and the cellular oxygen extraction. Oxygen uptake efficiency slope represents the rate of increase of oxygen uptake in response to a given minute ventilation. It indicates how effectively oxygen is extracted and taken into the body and indicates the status of systemic and pulmonary perfusion. This is influenced by things such as pulmonary dead space, which is also very important in our congenital patients. Work efficiency is a measure of the metabolic cost of performing external work and can be decreased in patients with reduced oxygen delivery to working muscle. The respiratory exchange ratio, which is the ratio of CO2 exhaled to O2 uptake per unit time, is a marker of effort and the contribution of anaerobic metabolism. An RER of greater than 1 or 1.08 is generally considered a good effort on the part of the patient. The ventilatory threshold is the point at which anaerobic metabolism supplements aerobic metabolism, and the ventilatory equivalent is the amount of ventilation needed for the uptake of a given amount of oxygen, and also is a reflection of physiologic dead space as well. It's important when you receive these results to interpret them in two contexts. You can interpret them, what percentage of a normal max VO2 has this patient achieved? But it's also important to say, how has this patient achieved compared with other people with the same diagnosis? As you can tell, the top line is healthy controls, and you can see with each decade of life, there's a decreased max VO2, as would be expected. But you see the lower lines reflect different diagnoses and how their exercise capacity can be expected to change with time. I think one of the more interesting ones is, the triangles, which dips in the 40 to 49 year bracket, because that's your CCTGA, and that's around the time where we usually start to see dysfunction of the systemic right ventricle. So knowing where your patient falls, not just in terms of in comparison with a normal patient, but also in comparison with patients of the same diagnosis, will help you interpret those results better. Why is functional testing so important? It's because we know that our patients are widely varied in their ability to tell us about their symptoms. You have on the one side the minimizer, who will always tell you, no matter how blue they are, no matter even if they can't even get through that one sentence as they're trying to tell you they're fine, they'll tell you they're fine. And then on the flip side is the sort of medical student's worst nightmares, the diffusely positive review systems. Because you get stuck there for 2 hours having to elaborate on everything they say yes to. But there's everything in between too. And a couple of weeks ago, I had a patient who I met for the first time who just sat there on the exam table with her arms crossed, not saying much of anything. And she's not going to tell me a whole lot about her exercise capacity because she just doesn't want to. So having objective data is key. Exercise testing. How do we use this information in a clinical setting? Well, it's a very important test for us to monitor how patients are responding, for example, to medication therapy. Especially nowadays, the most important new group of medications, the pulmonary vasodilators, it's very important to see, all right, do we see this patient's exercise capacity is declining over time? Do we think it's because they have elevated pulmonary vascular resistance? Will they benefit from a pulmonary vasodilator? And if they do, how much are they benefiting? So having, say, a max VO2 before and after initiation of certain medications can be very helpful. These are the main pictures that I get to put in my slide set about cardiopulmonary exercise testing. Everybody else got oohs and ahs. I've got pictures of these guys. So you can choose to ooh or not. Oh, I know. Oh, you're next, Treadmill. Imaging. So, if something is changing with a patient, if you've done an echo, you see that their exercise capacity is decreasing, and echo is not giving you that information, why? Maybe it's time to move on to more advanced forms of imaging, CT, MRI. Is it time to refer them to your interventional colleagues? Is it time for some catheter-based assessment of pressures, hemodynamic assessment? Is it time for interventions in the cath lab? Do they need something coiled because they desaturated with exercise, telling you that they have venous shunts? Do they need the Melody valve, our favorite? What do they need? And also, how much do they improve after you've done something for them? Do they improve as much as you expect them to? Or do you need to continue looking for other things that you might be able to do for them, such as surgical intervention? As good as our catheters are, they can't do everything we need to do for our patients, and sometimes they do have to undergo their second, third, fourth, fifth, and beyond sternotomy, unfortunately. And that's when we send them to our surgical colleagues, and then we can reassess them once again afterwards to see how much they've improved. Maybe they need an electrophysiology evaluation because when they exercise, they had really poor exercise capacity because they had chronotropic incompetence or because they had exercise-induced arrhythmias. So maybe they need a visit to your friendly electrophysiologist. Maybe things have gotten so dire and you've asked Jamil and you've asked Dr. Lax and you've asked Kevin Shannon, and they say, we just don't have anything else to offer this patient that's going to make them better. Maybe it's time to think about a transplant. One of the most important aspects of our job as providers for the congenital heart disease population is talking about pregnancy and talking about family planning. And exercise testing can be extremely useful to see how a patient responds to exercise stress, because you can then use that information to try to predict how they're going to respond to the physiologic stress of pregnancy as well. Research. For each of these interventions that we're investigating or doing now, whether it's medications, whether it's valve replacements, surgeries, ablations, research depends on our ability to quantify and report back how patients are doing. And 6-minute walks are good for something, New York Heart Association class will give you some sense, but really having that cardiopulmonary exercise test information is really important for us to further our field and learn better how we can help our patients. A lot of these patients early in life are very, very sheltered. Lots of patients tell me, well, I was put in a bubble when I was young because I had congenital heart disease and I was told not to exercise. And so once they get into adulthood, we may have different recommendations for them. We may tell them, you know what, you actually can exercise. And sometimes going through a cardiopulmonary exercise test so that they can prove to themselves, sometimes prove to their parents who are coming with them still to their appointments, how much they can do and how much they can do safely. And sometimes that helps mom or dad feel better about letting their son or daughter go to college or go do exercises or participate in sports. It's also helpful to give people an exercise prescription. We know that we can condition our congenital heart patients to a higher max VO2. To the extent that max VO2 correlates with quality of life, we think that this will provide an improvement in their quality of life because they can do more now. And our goal, after all, is to help our patients live longer and live better. So that living better aspect is very important. But we also want to think about their long-term cardiovascular health as well. These patients are now living into their 50s, 60s, 70s, and starting to get affected by the same degenerative type of problems that all of us will. And so having them stay healthy, stay active, and start looking after themselves just to protect their long-term cardiovascular health is important. So an exercise prescription can be a very important part of that. And most importantly, prognosis. Some patients will be a little bit more direct than other patients in asking about prognosis. And we know that peak VO2 does give us some prognostic ability. This is a study published in Circulation 2012, which demonstrates that the peak VO2 correlates with estimation of medium-term 5-year survival. And you can see, and you can have this slide, I think, in your handbook as well, that the lower the estimated peak VO2 in terms of percentage of predicted, the lower their estimated 5-year survival rate. The same actually applies in the middle box on the top there for the heart rate reserve. We think that heart rate reserve, if it's impaired, reflects a decreased ability to increase cardiac output appropriately and can be associated with increased morbidity or mortality as well. And this holds true for whether you're looking at the cyanotic patients, and it's true on or off non-chronotropic, negative chronotropic agents, which is what the bottom slides show you. So I hope I've convinced you that despite your patients rolling their eyes at you, which they will, sometimes twice, they'll do a full 720-degree eye roll, that this is important. And when you talk to your patients, you can tell them these are the reasons that doing functional testing, as annoying as it is, as embarrassing as it is, as uncomfortable as it is, really gives us important information to help us know where to go next for you and what that next step will be. So I just wanted to say thanks to my team at UCLA and also my folks down at UC Irvine as well.